These are 17 pieces of hard advice that doctors have been telling patients for decades, and that major clinical trials have now reversed, weakened, or completely demolished. If you are over 60, some of these reversals could save your life because the old advice isn't just outdated. In several cases, it was actively dangerous to people your age, especially if you're a Medicare patient dealing with overused procedures or following guidelines from a different era of medicine. Today, we're going to walk through them one by one. We'll look at what doctors used to say, what the evidence actually shows now, and which ones matter most for seniors. This isn't about blaming doctors. Most of them were following the best guidelines available at the time. But medicine changes, and the guidelines you were given 20, 30, or 40 years ago may no longer reflect what science knows today. Let's start with the single most important one. Number 1 on our list is daily low-dose aspirin for primary prevention. For roughly 30 years, from the late 1980s until 2018, tens of millions of healthy Americans took a daily baby aspirin to prevent a first heart attack. By the mid-2010s, 30 to 40% of adults over 50 were taking aspirin this way. Your doctor probably recommended it. Your friends were on it. It seemed like common sense. Then, in 2018, 3 massive clinical trials changed everything. The most important one for seniors is called ASPREE. It was published in the New England Journal of Medicine in September 2018. Researchers studied 19,114 healthy adults aged 70 and older, with a mean age of 74. They gave half of them 100 milligrams of aspirin daily and half a placebo, and they followed them for nearly 5 years. The results were stunning. Aspirin provided no significant cardiovascular benefit. But major hemorrhage was 38% higher in the aspirin group. All-cause mortality was 14% higher with aspirin, and cancer-related death was 31% higher. A drug people were taking to live longer was actually killing them faster. 2 other trials published that same year, ARRIVE and ASCEND, confirmed the pattern. In ARRIVE, gastrointestinal bleeding roughly doubled with aspirin. In ASCEND, which studied diabetic patients, the small reduction in vascular events was essentially canceled out by a 29% increase in major bleeding. The guideline changes followed quickly. In March 2019, the American College of Cardiology and American Heart Association gave aspirin a Class III harm designation for anyone over 70. Then, on April 26, 2022, the U.S. Preventive Services Task Force made it official, a D recommendation against starting aspirin for primary prevention in adults 60 and older. Dr. Eric Topol of Scripps Research put it bluntly in January 2026. He said, quote, "It's hard to turn around a medical myth exemplified by the notion that low-dose aspirin is safe and effective in healthy adults for primary prevention of heart disease, especially in people aged 60 years and older," end quote. Dr. Stephen Nissen of the Cleveland Clinic said in April 2022, quote, "If you are really healthy, you will do more harm than good with daily aspirin. Your risk of bleeding will exceed the benefits," end quote. And yet, despite all of this, around 34% of Americans aged 70 and older without heart disease were still taking aspirin as of 2021. If that's you, this is a conversation to have with your doctor soon. I want to be clear. If you've already had a heart attack or stroke, the rules are different. This is about primary prevention, meaning people taking aspirin just in case. That brings us to number 2, stents for stable chest pain. For decades, if you had stable angina, meaning chest pain that came on with exertion, the standard treatment was a stent. The theory was simple and intuitive. You have a clogged pipe, you open the pipe, you prevent the heart attack. By the mid-2000s, over 1 million coronary stent procedures were performed annually in the United States, and roughly 85% of those were done electively in patients with stable coronary artery disease. 3 landmark trials dismantled this practice. The first was Courage, published in the New England Journal of Medicine on April 12, 2007. It studied 2,287 patients with stable coronary disease. Death or non-fatal heart attack, 19% in the stent group, 18.5% in the medication-only group, no significant difference. Then came ORBITA, published in The Lancet on November 2, 2017. This was the first sham-controlled stent trial. 200 patients with severe single-vessel blockages were divided into 2 groups. One got a real stent, the other got a fake procedure where a catheter was placed, but no stent was actually inserted. The patients didn't know which they received. Exercise time improvement between the 2 groups was not statistically significant. Then the biggest trial of all, ISCHEMIA, Published in the New England Journal of Medicine on March 30, 2020. 5,179 patients. The invasive strategy with stents was compared to conservative medical therapy. The primary endpoint at 5 years, 16.4% versus 18.2%, not significant. All-cause mortality, 145 deaths versus 144 deaths, essentially identical. Dr. David Brown and Dr. Rita Redberg wrote in The Lancet after ORBITA, quote, "There are no benefits for PCI compared with medical therapy for stable angina," end quote. Dr. Redberg of the University of California, San Francisco explained why. Atherosclerosis is a generalized, diffuse process, and stents treat only discrete lesions. Heart attacks are more likely to occur in arteries that have some mild plaquing, but are not blocked or narrowed much, end quote. And this matters especially for seniors, because an analysis by the Lown Institute in 2023 examined Medicare claims at 1,773 hospitals between 2019 and 2021. They found over 229,000 stent procedures that met criteria for overuse. That works out to one unnecessary stent every 7 minutes. More than 20% of stents in Medicare patients were placed unnecessarily. The cost to Medicare was $2.44 billion over 3 years. Number 3 is much simpler, but it affected almost everyone: eggs and dietary cholesterol. Starting in 1968, the American Heart Association recommended no more than 300 milligrams of dietary cholesterol per day and no more than 3 eggs per week. Every edition of the dietary guidelines from 1980 to 2010 kept that 300 milligram cap. Egg consumption in America dropped from 3.6 eggs per week in the early 1970s to 1.8 eggs per week by the late 1980s. Here's what researchers eventually discovered. Dietary cholesterol has minimal impact on blood cholesterol because when you eat more cholesterol, your body simply makes less of its own. It's a compensatory mechanism. Meta-analyses examining around 350,000 participants across 16 studies found no relationship between egg intake and cardiovascular disease, heart disease, or stroke. The reversal came gradually. In 2013, the American Heart Association and American College of Cardiology concluded there was insufficient evidence to determine whether lowering dietary cholesterol reduces LDL. In 2015, the Dietary Guidelines Advisory Committee formally removed the 300 milligram cap, stating that available evidence showed no appreciable relationship between dietary cholesterol and blood cholesterol. In 2019, the American Heart Association said healthy adults can include up to 1 egg per day. But the old message stuck. As of 2021, 22% of Americans still intentionally limited their egg intake, and 10% specifically cited cholesterol concerns. That's decades of unnecessary food restriction based on advice that was quietly reversed. Number 4 is the entire philosophy behind that egg advice: the low-fat diet for heart health. In 1977, the U.S. Senate's dietary goals recommended cutting total fat from 40% to 30% of calories. The 1992 Food Guide Pyramid made low-fat eating official national policy. For decades, the American Heart Association recommended limiting total fat to under 30% and saturated fat to under 10% of calories. The food industry responded by replacing fat with sugar and refined carbohydrates in processed foods. Then came Preventive, published in the New England Journal of Medicine in 2013. 7,447 participants aged 55 to 80 at high cardiovascular risk. The Mediterranean diet groups, which were high in olive oil or nuts, showed a 30% reduction in major cardiovascular events compared to a low-fat control diet. A high-fat Mediterranean diet was actually superior to a low-fat one. Then the Pure study, published in The Lancet in 2017, followed around 135,000 people across 18 countries. It was led by Dr. Salim Yusuf of McMaster University. High carbohydrate intake, above 77% of calories, was associated with 28% higher mortality. Total fat, including saturated fat, was associated with lower total mortality. Saturated fat even showed an inverse association with stroke. Dr. Yusuf, speaking at the European Society of Cardiology in 2017, said, quote, "Study after study has refuted this, and yet the traditional church has stuck to the traditional way of thinking," end quote. Now, I need to be fair here. This is genuinely contested. The American Heart Association has not reversed its position on saturated fat, and the 2025 to 2030 dietary guidelines released in January 2026 still recommend limiting saturated fat to under 10% of calories. The key lesson isn't necessarily that butter is a health food. It's that for decades, people were told to replace saturated fat with refined carbohydrates and sugar, and that swap provided no benefit and may have been actively harmful. Number 5 is one of the most tragic examples in medical history, avoiding exercise after a heart attack. From 1912 through the 1950s, the standard treatment was strict bed rest for 4 to 6 weeks. Patients were confined to bed. Sitting in a chair was prohibited. Turning from side to side required assistance. Hospital stays lasted a month or longer. Heart attack mortality in that era was around 35%. Dr. Bernard Lown described the madness of it. He wrote, quote, "Physicians convinced themselves and their patients that complete bed rest was the price of survival." Visiting Martians, witnessing this travail, might have judged the scene differently, regarding hospitals as prisons where inmates were subjected to a unique form of torture. End quote. In 1952, Dr. Samuel Levine and Dr. Bernard Lown published their paper on what they called armchair treatment. They simply let patients sit in a comfortable chair for 1 to 2 hours a day. Hospital mortality more than halved. Depression diminished, pulmonary emboli nearly vanished. They faced enormous opposition from the medical establishment. Lown later estimated that perhaps 100,000 lives per year were saved by this simple change. Today, the evidence for cardiac rehabilitation is overwhelming. A 2021 Cochrane systematic review of 85 randomized trials involving 23,430 participants showed a 26% reduction in cardiovascular mortality at 12 months. Long-term follow-up beyond 3 years showed a 42% reduction in cardiovascular death and a 33% reduction in repeat heart attacks. Cardiac rehab is now a Class 1 recommendation from every major cardiology society, and yet only 14 to 35% of heart attack survivors actually enroll. Number 6 affects women specifically, hormone replacement therapy for heart protection. Throughout the 1990s, HRT was the most commonly prescribed medication in the United States. Observational studies suggested it reduced heart disease risk by 40 to 50%. The U.S. Preventive Services Task Force gave it a B grade. Every major medical society supported it. Then, the Women's Health Initiative changed everything. The estrogen plus progestin arm was stopped on May 31, 2002, and the results were published in JAMA on July 17, 2002. The trial enrolled 16,608 postmenopausal women with a mean age of 63. Heart attacks were 29% higher in the HRT group. Stroke was 41% higher. Pulmonary embolism was 113% higher. Invasive breast cancer was 26% higher. HRT prescriptions plummeted almost overnight. The U.S. Preventive Services Task Force downgraded HRT from a B to a D recommendation for chronic disease prevention. The FDA applied black box warnings to all systemic estrogen products in 2003. Today, HRT is supported for menopausal symptom relief in carefully selected younger women, but it is not recommended for cardiovascular protection. Number 7 is one you've probably heard from friends and maybe even from your doctor. Moderate alcohol is good for your heart. This belief became mainstream on November 17, 1991, when Morley Safer aired a 60-minute segment about the so-called French paradox featuring French epidemiologist Serge Renaud. Red wine sales in the United States rose 39% in 1992. For the next 30 years, a glass of red wine a day became accepted medical wisdom. The problem was something called the sick quitter bias. Many observational studies classified former drinkers, people who had quit drinking because of health problems, as abstainers. That made moderate drinkers look healthier by comparison, when really they were just being compared to sick people. Mendelian randomization studies, which used genetic variants to get around this bias, demolished the claim. The China Kadoorie Biobank study, published in The Lancet in 2019, following 500,000 people, concluded that the apparently protective effects of moderate alcohol intake against stroke are largely non-causal. A 2022 study published in JAMA Network Open analyzed 371,463 UK Biobank participants. The authors wrote, quote, "Alcohol intake should not be recommended to improve cardiovascular health," end quote. A massive JAMA Network Open meta-analysis in March 2023 examined 107 cohort studies covering more than 4.8 million participants. When the researchers controlled for the biases, no level of daily alcohol consumption showed a mortality benefit. On January 20, 2022, the World Heart Federation declared, quote, "No amount of alcohol is good for the heart," end quote. The World Health Organization followed in January 2023 with, quote, "No level of alcohol consumption is safe for our health," end quote. Number 8 takes us into drug development, raising good cholesterol with drugs. For decades, HDL was called good cholesterol, and pharmaceutical companies spent billions trying to raise it with drugs. The results were a catastrophe. Torcetrapib from Pfizer was terminated in December 2006. It raised HDL by more than 60%, but it caused a 25% increase in the primary endpoint and a 58% increase in mortality. Dalcetrapib from Roche was stopped in May 2012 for futility. Evacatrapib from Eli Lilly was stopped in October 2015, also for futility. Evacitrapib raised HDL by around 130% and lowered LDL by 37%, and yet the primary endpoint showed no benefit whatsoever, 12.9% versus 12.8%. Dr. Stephen Nichols said at the time, quote, "Here we've got an agent that more than doubles the levels of good cholesterol and lowers bad cholesterol and yet has no effect on clinical events," end quote. The lesson from genetic studies was clear. Variants that naturally raise HDL do not lower cardiovascular risk, but variants that lower LDL do. HDL is no longer a therapeutic target in any major guideline. Number 9 is closely related, adding niacin to statins. Based on the 1975 Coronary Drug Project, niacin was recommended for decades because it raised HDL and lowered LDL, triglycerides, and lipoprotein a. The FDA even approved combination drugs like Adviker in 2001 and Simcor in 2008. 2 trials ended niacin's reign. AM-HI, published in the New England Journal of Medicine in 2011, studied 3,414 patients. The primary endpoint was 16.4% with niacin plus statin versus 16.2% with statin alone, no benefit. HPS2 Thrive, published in 2014, studied 25,673 patients. The primary endpoint was 14.5% versus 15%, not statistically significant, and serious adverse events were significantly increased. On April 18, 2016, the FDA withdrew approval of Adviker and Simcor. Dr. Stephen Nissen put it plainly, quote, "There is no evidence for any meaningful benefit for addition of niacin or fibric acid derivatives to statins. In the absence of benefits, there remain only harms," end quote. Number 10 is the tragic irony of 1980s heart advice, margarine instead of butter. Starting in the 1980s, as the anti-saturated fat campaign intensified, margarine was actively promoted as a heart-healthy alternative to butter. Medical societies supported the switch. Major fast food chains replaced beef tallow with partially hydrogenated vegetable oils. The ABIS trial, published in August 2024, showed that interrupting beta blockers more than 6 months after a heart attack did not improve quality of life. I want to be absolutely clear here. If you have heart failure or reduced pumping function, beta blockers are still clearly indicated. This change is about patients with normal heart function. The most surprising result came from the DECAF trial, published in JAMA in 2025. It studied 200 adults with atrial fibrillation. The coffee group had a 39% lower hazard of AFib recurrence over 6 months compared to total caffeine abstinence. Number 13 is about how cholesterol is measured. For decades, LDL cholesterol has been the primary number doctors watch.